Now, now mute me.
Well, it's perfect. It's really wonderful to meet everybody. My name is John Gore. I'm a urologist and professor at the University of Washington in Seattle, Washington. My main practice is actually urologic oncology. So I'm a urologic oncologist, and I'm the program director for our fellowship in urologic oncology. I responded about this topic in part because I also used to have a longstanding practice at our men's health center, which was focused exclusively on the management of male voiding dysfunction. And I was part of a grant-funded study from our NIH, our National Institutes of Health, which was trying to better understand some of the characteristics and trends in urinary dysfunction in men and women and how we can potentially make that better. And so there was a lot of alignment between what we were doing in research and what I was doing in clinical care. I will say I used to do about 50 TURPs a year, and I don't do as many anymore because I don't have that men's health practice. But I do love talking about TURPs, and I am a big believer in TURPs. So I'm going to share my screen. And I'm happy for this to be interactive if you guys would like. You can use the chat or you can just unmute yourself. Let's see here. So the goal of today is to talk about tips and tricks and how I think about TURPs in a way that sort of minimizes some of the risk of the TURP, maximizes efficiency, and avoid some of the problems that people sometimes get into when they're first starting out doing TURPs. Importantly, TURPs used to be one of the commonest surgeries here in the US that we did. So back in the 1980s, the two commonest surgeries in the US were cataract surgery and TURPs. And those are just two of the commonest problems that people have as they get older. All men have changes in their urinary symptoms as they get older. I'm 45. My urinary symptoms are different than they were when I was 25. That is a universal truth. The severity of the symptoms is kind of interesting because it doesn't perfectly correlate with how big someone's prostate is. And so in general, as your prostate gets bigger, the more likely you are to have urinary symptoms, but it's not a perfect correlation. There are men with a very small prostate who have incredibly bothersome, severe lower urinary tract symptoms, and there are men with, a small baseball-sized prostate who are doing a-okay. In general, the bigger it is, the more likely you are to have symptoms. But urinary symptoms are very multifactorial, and there are a lot of inputs that go into people's urinary health, including their fluid intake patterns. This is sort of my do as I say, not as I do coffee intake. Life stresses can intercede with urinary health, especially when it relates to sleep. One of the hardest problems that we have to treat in urology is nocturia. And a big reason why is it's not a simple solution. So if a man has a weak urinary stream, that is almost always BPH. I mean, it can be a stricture, it can be related to their bladder function, but more often than not, that is a BPH related problem. If they wake up at night 2 or more times to urinate and it's bothersome to them, that isn't always a urinary problem. That can be a sleep disturbance or other issues that affect that. And we do have some really great medications for BPH, but their success is variable. And what I always explain to patients is that if your symptom burden is here, and I give you tamsulosin, it's going to improve your symptom to here. But if I do a TURP, it's going to improve your symptom burden to here. And so even when they work the best, the medications we have for BPH are moderately successful. So how do we quantify the severity of BPH? Well, I always tell patients that we try to do this as best we can subjectively and objectively. And subjectively, the standard is the International Prostate Symptom Score, and I'll talk about that in a second. And then objectively, we typically use things like their uroflow or their post-void residual urine. I will say, when I had a very busy male voiding dysfunction practice, I did more urodynamics than I do now, but I didn't do a lot. And I really did them in the setting where I was worried that a man might have bladder failure. where it was really a pump problem, not a pipe problem. In general, we use these to define the severity of the treatment, but I will say on the IPSS, I use the bother score a lot. If a man's subjective symptoms are bad, but they're not bothered by it, I'm hard pressed to twist their arm into doing something like a surgery. So these are the categories on the IPSS, and a lot of these can be broken down into voiding symptoms, things that are more indicative of bladder outlet obstruction, like incomplete emptying, intermittency, weak urinary stream, straining to void, and then other things that might be more indicative of storage urinary symptoms, things that might be representative of an overactive bladder, like urinary frequency, urinary urgency, and nocturia is sort of this mixed urinary symptom. I am a big fan of voiding diaries. I think voiding diaries give you a lot of insight into the daily, drinking and voiding patterns that a lot of men have. And a lot of men will tell you that their symptoms are situational. They may be different at work than they are at home. And that goes a lot into how I think about helping them. And so, our voiding diaries are based on the voiding diaries that we give to women to assess their mixed urinary incontinence. It's a little different for men. Typically full bore incontinence is less common. I'm most interested in volume of intake, volume of output, and frequency. And obviously, if they have an associated urge, that just helps you understand how much of a component overactive bladder is in their symptom complex. So these are obviously some exemplary uroflows. That's an ideal uroflow. That's what our residents can pee like. That's not me. But on the right, you can see a very classic bladder outlet obstruction uroflow. This is an intermittent pattern with a suppressed peak flow. And you can see that it has this peak and valley pattern indicative of maybe even some Valsalva voiding. And then we always supplement that with a post-void residual with the bladder ultrasound scan. For urodynamics, in general, the urodynamics that I'm doing, I'm most interested in contractility and compliance. So the main reason I'm doing it is to fill their bladder, understand if they have normal sensation, do they feel full when they should feel full? And then when they void, what's their contractility like? It can illustrate, overactive bladder. And it's not uncommon for some older men to see evidence of, detrusor instability at lower volumes. And that can be a really difficult problem to treat. And I'm happy to talk about that. But like I said before, it's really not routinely necessary. If a man has very classic bladder outlet, obstructive symptoms, urodynamics are unlikely to change your management plan. Other evaluations that we think are important, it's not critical to routinely get a creatinine. You do sometimes unearth CKD, chronic kidney disease, or kidney disease that might actually be related to chronic urinary retention. So I do tend to get it more than I don't, but it's not mandatory. A urinalysis without a culture is pretty standard in my practice. And then PSAs, the point of this lecture is not to get into shared decision-making around PSA testing, but I'm happy to talk about my views about PSA testing. Bladder irritants are very, very common in my patient population here in Seattle. A lot of caffeine drinkers. There is this sort of scourge of crazy Diet Coke drinkers, which has a little bit of caffeine still in it, and it has some other things that are irritating to the bladder. But caffeine is number one, alcohol is number two. These are the commonest things that I find affect bladder health. Tobacco smoking can affect it as well, and certain foods can impact your bladder health. And so it's important to assess what role these things might be playing on your patient's urinary symptoms. I have patients that tell me, I just know if I have a glass of red wine, I'm going to be up 3 times in the night. But sometimes I just want to have a glass of red wine. So what are some behavioral interventions? So I'm really big on behavioral interventions because, to be honest, because they work. For nocturia or bothersome urinary frequency, you can actually do some fluid restriction. It's to a limit, but some fluid restriction can definitely help patients, but you don't want them to overly fluid restrict where they dehydrate themselves. What I focus more on is shifting fluid intake. Usually you can manage urinary frequency better during the daytime than at night when it's going to affect your sleep quality. So if we can shift your fluid intake to the daytime, and then at night, try to minimize your fluid intake within 4 hours of bedtime. The things that I typically counsel patients, number one, try to have a consistent bedtime. That's not easy for everybody to do. And some patients will tell you, well, some nights I go to bed at 9, some nights I go to bed at 11. And one of the first things I say is try to go to bed at the same time every night. And that way you can make your nighttime more predictable. And then you can walk back 4 hours and say, well, if I'm going to bed at 10 o'clock every night, after 6, I'm going to do my best to minimize my fluid intake. And that alone can help a lot. Bladder training, especially during the day, can be really helpful, where you set kind of a threshold. So if your goal is 2 hours between voids, if it's less than 2 hours, the patients try to hold it, with the caveat that I don't want them to hold it if they're having pain or fear of incontinence. But if it's a low-level urge that we think might represent a low-level bladder spasm, then they try to hold it and see if they can sort of functionally retrain their bladder. So when do we do a TURP? Well, I have a pretty low threshold to do TURPs. And a big reason why is it's just a very effective treatment. It makes men's urinary health and overall quality of life better. The very obvious absolute indications are if you can't pee despite medical therapy, if you have refractory bleeding due to BPH or recurrent urinary tract infections because of incomplete emptying. Bladder stones are considered an absolute indication for a TURP, but I think it's more a relative indication. Oftentimes if they are naive to BPH medications, we can treat them medically and just treat the stones and then come back to do a TURP later on if they need it. And if they present with urinary retention with acute kidney injury, those patients in my practice are just committed to a Foley catheter until they get to their surgery and then a TURP. Especially if their kidney function normalizes with a catheter in place, your goal is long-term kidney health in those patients. Very important relative indications. And in my practice, these were really the dominant source of the patients that we would see. So obviously, if they have bothersome symptoms where medical therapy doesn't seem to help, but I think this is a really important one, severe urinary symptoms at a young age. I also take care of those men who have bladder failure in their 70s and 80s, in large part due to chronic bladder outlet obstruction. Their bladder has just been squeezing against a big prostate for so many years that it's just tuckered out. And I think that sometimes we overtreat with medical therapy and we allow those patients to continue to suffer from a bladder that is overly stressed and exhibits high voiding pressures because it's still squeezing against an obstructing prostate to the point where it fails. So if I see a man in their early 60s or younger with more severe voiding lower urinary tract symptoms, I will talk to them even before I start medical therapy about a TURP. I think it's really important. And then sometimes you have patients who have overactive bladder, but maybe it's actually secondary overactive bladder, where that same bladder that's been squeezing against an obstructing prostate for so many years is now an overactive bladder. It's a thickened, less compliant, overactive bladder. And you're very challenged to manage those with anticholinergic or other bladder relaxant medications because you're trying to navigate this push-pull of helping them pee, but also trying to control these spasms that affect them. And the treatment for those spasms affects their bladder contractility, which increases their emptying. And so it's this kind of really challenging push-pull. And sometimes doing a TURP in those patients allows you to more effectively manage their overactive bladder. So what are the outcomes? Well, TURPs work. I mean, they're a really, the joke that I used to always make in my practice is my main practice is a cancer practice. I mainly treat kidney cancer and bladder cancer, but nobody is happier than a man who can't pee, who can suddenly pee really well. And so some of the most satisfying patients in my clinical practice are these TURP patients. I would say this is even a short estimate. This is from the AUA, but greater than 3/4 of men having a TURP are very satisfied with the outcome. The two things that you can practically guarantee are going to get better are the force of the urinary stream and their post-void residual. Those are the two things that are almost guaranteed to get better. If they have a component of urgency to their symptoms or they have bothersome nocturia, I try not to be too promising of any major improvement. What I always say is, if those things are persistent after your TURP, we're going to work on them together. But the two things we know are going to get better are your flow and your emptying. There are risks. Bleeding is clearly a problem in the short term. I tell most men that the bleeding is going to persist for 10 to 14 days, but there are some men that have this persistent residual bleeding beyond a month. It's usually not a big deal, but it bothers them. And so it's important for them to know that that's not abnormal. Obviously, short and long term, they're going to have decreased semen output with ejaculation, and they just need to know about that ahead of time. So scar tissue, that happens. There are patients that develop sort of a stubborn bladder neck contracture that is most common in men with smaller prostates. So the risk for that is much higher in men with a prostate that is 30 cc's or less. And in those patients, we tend to default to an incision of the prostate rather than a resection of the prostate, really just to minimize that risk. Incontinence is uncommon. This is a very anatomically precise surgery, and so the rates of incontinence are very low. Regrowth does happen. So the joke I always make to patients is it's sort of a 5-year guarantee, 10-year warranty. So 5 years is usually a practical guarantee. They should have durable symptoms for about 5 years. Beyond that, they can have some regrowth, and the rate and pace of regrowth is highly variable. And I think it has a lot to do with that man's sort of testosterone, DHT, hormonal access. I've had some patients really have impressive regrowth adenomas in only like 5 or 6 years after their TURP. But if a man's getting a TURP in their early 60s, I often counsel them that it's not out of the realm of reason that they might need a re-TURP in their lifetime. New onset impotence is rare. Bladder injury is incredibly rare, but we'll talk about some ways to prevent that. So some general rules on how to do this. And I will say when I signed up for this talk, I was hoping to make a cool video, and I'm sorry that I don't have that, but I'm going to try to be as descriptive as possible in my language. The first thing is just anatomic identification. This should be a systematic process. You should have your system for doing a TURP. So this is my system. It doesn't have to be your system, but a lot of things that we do in surgery, we do because that's what we do. For this, I try to have a rationale for all the decisions that I make in this pathway. And so I'll talk to you about that. But whatever your order of these numbers is, just be systematic about it. Don't do a TURP this way one day and that way the next. It should be sort of the same process that you stepwise go through every time. And that's just how you stay out of trouble. So the first thing is just anatomic orientation. You are trying to make sure that you see all the relevant structures that map out, how you're going to approach this TURP. So you're going to see, do they have a substantial median lobe? The median lobe is almost always posteriorly oriented, but some patients actually have an anteriorly oriented median lobe. So make sure you look up too. Are the ureteral orifices, away from the bladder neck, or are they fairly close? Do you need to do some maneuvers to make sure you protect the ureteral orifices as part of your resection? I have never had to put up ureteral catheters or stents. I've seen that described in some places to avoid injury. And that includes in patients that have some significant J-hooking where the ureters are pulled into the base of the median lobe, because usually you can sort of resect away from the ureteral orifices. But I have seen that described where you're just worried about the proximity of the ureteral orifices to the median lobe. And obviously you want to map out your viru. And my main rationale for that is because I want to know, is this a prostate whose length is such that I can just park myself at the viru and do a very efficient TURP where I can just go from the bladder neck all the way to the viru in one swipe? Or is it a little bit of a longer prostate where I have to break up the anatomy of the prostate into 2 sections and kind of resect halfway and then resect back to the viru? And we'll talk about a process for doing that. I always manage the median lobe first. A big reason why is because the median lobe can be a little bit obstructionist to the flow of the surgery, in that you're going in and out with this resectoscope kind of repeatedly. You're periodically emptying the bladder, even with continuous flow. And so it's nice to get rid of the median lobe. It protects the ureters. So what you find is, as you resect the median lobe back to the bladder neck, the distance between where the bladder neck actually is and where the ureteral orifices are, it gets longer. And so you actually, the more you manage the median lobe, the more you actually get the ureteral orifices out of the way of your dissection. So after managing the median lobe, I then carry that plane of dissection back to the viru. And this is a really important part of the case. So the reason I do this first, because I've seen some people do this last, the reason I do this first is, number one, it sets up the anatomy. Now, when you do the lateral lobes, you have an endpoint as you process your dissection laterally down to the floor. So it gives you an endpoint for your dissection. It also creates a channel so that as you're resecting, those chips have a pathway to go up into the bladder so that you're not navigating these chips just sitting in your face the whole time. So it creates a preliminary channel that allows the chips to go up and away. And the goal of this floor dissection is not to get to the capsule. This is a mistake that I see a lot. And I actually was called in to help out on a case where they actually perforated through the bladder neck into the peritoneal cavity because they undermined the bladder neck so severely because they were trying to resect back to the capsule. Well, the capsule is pretty thin posteriorly, but there's also, there's no benefit to helping their voiding to create this sort of, neck-like, billowing neck-like bladder neck posteriorly. And what you really want is a smooth funnel-like transition between the bladder neck and the viru. And so what you want to do is look at where the anatomy of your bladder neck is, look at where the anatomy of your viru is, and create a smooth transition from one to the other. Oftentimes, men have this sort of what I call a steep prostate, where as you resect the bladder neck, you find that as you get closer to the viru, you actually don't have to resect a lot of the tissue right in front of the viru because the prostate has such a steep curve that once you resect that upper steep part, it's already smoothed out for you. And then lastly, you do the lateral lobes, and that's often just the really fun part. It's usually the thickest part, so you're resecting the most adenoma. But if you've set everything up well, you set up your median lobe, you set up the floor dissection, the lateral lobes should be pretty darn easy. And I always do this anterior to posterior. And in that way, I set my bar to get to the transverse capsule, and then I work my way posteriorly to the floor. I have seen people who like to do this posterior to anterior because what they like to do is let the prostate fall into their face. But I actually think there's more room anteriorly. And I can always go under and lift up the posterior lobe and shave that down later. And I think it's easier to do this anterior to posterior. I remember the people that taught me how to do a TURP always told me to stay away from the anterior lobe. And I've just carried that forward a little bit. So I don't do a lot of anterior dissection unless it's really just hanging down in your face. And then you just want deliberate hemostasis. Just like you want to be systematic in how you approach the TURP, you want to be systematic in how you approach hemostasis. So you want to make sure that you're going, typically from the bladder neck to the viru. You want to go to the areas that maybe you encountered a little bit more bleeding as you were going through your resection. But what I typically do is every time I go in to do a round of hemostasis, I start at the bladder neck. I try to find the mucosal edges because that's where often you encounter bleeding. And then you just want to work your way systematically through the floor and through the lateral lobes. Whatever your system is for doing it, you just want it to be a system. So a couple schematics. So this is just, I think, a great lateral sagittal view that shows you kind of how a median lobe often protrudes posteriorly into the bladder base. And, obviously the first thing that you want to do is you want to make sure that the ureteral orifices are at least visible. Some people like to mark them. So what they'll do is, they'll put a little score right in front of the ureteral orifice. I don't typically do that. I think sometimes it's hard to re-identify. And what I prefer to do is I prefer to park myself right in front of the ureteral orifice and then pull back and do my first several shaves just distal to the ureteral orifice. And if you do that, you automatically create space instantaneously away from the ureteral orifice. So I'll go to the ureteral orifice, back straight up into the prostate fossa with my loop kind of catching whatever bladder neck or median lobe tissue is there, and shave that down. And that naturally elongates the bladder neck and pushes the ureteral orifice well away from you. The way these numbers are located, you're typically shaving down the anterior median lobe first. Because if you look at the bottom picture, what you're trying to do is you're not trying to resect that median lobe down to the bladder neck. The more that you have resected the bladder neck itself, the more you've over resected. What you're really trying to do is you're trying to hook with your loop that median lobe and lift it away from the bladder neck and resect it in the air. And that way you minimize some of the cautery that will impact, their early postoperative symptoms, their perioperative urgency and frequency, which can be really bothersome. And it makes it a much cleaner dissection. And it also contributes to that concept of sort of elongating the distance between the ureteral orifices and the bladder neck. So this is typically how I like to approach the median lobe, is shave it down from the top. And then what you'll see as you release it, there's more mobility on the median lobe, and you essentially want to reach over the top and shave it up. With the median lobe and the bladder neck, I tend to take shorter swipes, sort of shorter, more controlled swipes. And I tend to position myself pretty close to the bladder neck because I want this to be very anatomically precise. I'm not at the point in the surgery yet where I'm parking at a distance and taking long, huge swipes that are going to lead to very large, long chips. Here, if they're smaller chips, that's okay. I would rather do short, quick resection bites than longer, big ones, because with each one, I'm trying to reassess the anatomy of the median lobe. After the median lobe, I shave down the bladder neck. And I talked about how I think the floor is a really important part to start with. In the bladder neck, same thing. I really want to park myself right on the bladder neck and take these short swipes. Because once I establish the posterior lip of the bladder neck, where I see those circular fibers of the bladder neck, those circular muscle fibers, once I establish that level, I can just make basically a direct, smooth line between that level and the viru. So I'm going to just park myself at the bladder neck, and I'm going to start at the 5 and 7 o'clock positions. What this is doing is this is just essentially carrying that same concept of positioning yourself in front of the ureteral orifice and then coming back into the prostate fossa. And I love when this happens, when it creates sort of a mohawk in between, because now I have perfect anatomic delineation of the posterior level of my dissection on the right and left sides. And that middle part, now I can be a lot quicker. Now I can be a lot more aggressive as I shave that middle part down to the level of the bladder neck. In terms of instrumentation, so we do almost all of our TURPs with a bipolar device. Ours is from Olympus. And so we're doing these with saline. And in saline, if you get a little bit of bleeding, it really clouds your view a lot more than our old monopolar TURPs, where we're doing this in hypotonic solution. And so with the bipolar TURPs, it's really important to get kind of hemostasis as you go. Whereas, when you're doing these with a monopolar TURP, you want to get down to the base of whatever the base that you're resecting and then get hemostasis, because there's kind of no point in getting hemostasis until you get down to the base. With these bipolar TURPs, oftentimes with the bladder neck, there are a lot of perforating blood vessels. So oftentimes you're doing a lot of resecting and buzzing and resecting and buzzing. And then once you've kind of created this posterior plane, now this is where you really want to set that floor. And this is kind of a good schematic showing that if I leave a lot of posterior adenoma, and I think this is a little bit dramatic, this cartoon that I found, but if I leave a lot of posterior adenoma, I don't care. It's more important to me to create that smooth funnel-like transition from the bladder neck to the viru. The opposite I've just seen so many times where, a urologist has to use a wire to get a catheter in, or causes some problems because they've really severely undermined the bladder neck because they're trying too hard to resect a lot of the tissue in this area. So I will often kind of position myself at the bladder neck, walk back to the viru, and just see how I want to shape that posterior floor. And if I just take a little extra time here, it'll make me so efficient when I'm doing the lateral lobes, because I'll just be able to shave those all the way down, aiming for the floor that I've already set. So next is the lateral lobes. And like I mentioned, I really like to spend a lot of time getting my depth on the transverse capsular fibers up high. So I don't know why. I always tend to do the patient's right side first, my left side. It's, everyone has their thing. That's just my thing. So I always tend to do that side first. There are exceptions. So it's very common for men to have an asymmetric prostate where just one side bulges more than the other. And in that case, I will often do the more bulgy side first because it just creates space. And it's just physically hard to resect the smaller adenoma until you've gotten the bigger adenoma out of the way. But I like to go anteriorly. And, oftentimes I'll see the residents sort of shave here and shave there. And I don't like to do that. I like to create a gulf, sort of a depth down to the capsule at that 11 o'clock, 10 o'clock position, where I know that at that position, we are all the way to the depth that we want to be at. And now, as I do the next section, as I come down from 10 o'clock to 9 o'clock, I know what depth I'm aiming for, and I can keep working down to that same depth. As I start to get lower, as I start to get down to like 8 o'clock and 7 o'clock, now I'll start checking back and forth to see where my floor plane is. Because in the same way that we created that mohawk at the bladder neck, we start to create these mohawks in this posterolateral position of the lateral adenoma. And that really is a satisfying area because it allows me to shave those down with a lot of anatomic precision. In an ideal world, the patient has a prostate where you can just park at the viru, reach your loop all the way into the bladder and resect all the way back. Those are the funnest, most efficient TURBTs or TURPs. But sometimes a patient has a really big prostate, and sometimes that's just not physically possible. So different people do this different ways. When I learned how to do TURPs, I had some faculty on a big prostate like that who liked us to go all the way from the bladder neck, all the way to the viru in one depth. So basically at the 10 o'clock position, closer to the bladder neck, you resect down to the capsule, and then you pull back to the viru, and in that same depth at 10 o'clock, you resect down to the capsule. I find that to be more inefficient. So what I like to do is I like to score the prostate at the halfway point so that I have a visual marker that I know when I back my resectoscope up, that's where I'm going to stop. And then I like to resect in the same way from anterior posterior, from the midpoint of the prostate to the bladder neck. So from the midpoint of the prostate to the bladder neck, I resect all the way down to capsule fibers. And then I come back to the viru. And the reason I like to do it that way is because I think that avoids a lot of inefficient moving forward and backward, where you're passing the scope back to the viru to check the position of the viru, back to the bladder neck, back to the midpoint of the prostate. And so I essentially break the prostate up into two halves, and I do the front half first, closer to the bladder, and then the second half second, closer to the viru. A couple of just troubleshooting thoughts. So some men have gigantic median lobes. And I will say, as a field, so I did a lot of simple prostatectomies in residency. I don't know if you guys do a lot of simple prostatectomies. It's a brilliant operation. But more and more, my partners and colleagues in the community are doing that as a robotic surgery. And it's a very satisfying operation because the pneumoinsufflation of the robotic surgery means that a lot of the venous bleeding that you typically have with an open simple prostatectomy just isn't so bad. But if someone has a large median lobe and you're doing a TURP, the most important part is to maintain your orientation. And so this is why I really don't want to be too far away from the tissue. And this is why I maintain sort of a close view of everything. But I reorient myself frequently. So it'll be maybe a subtle move, but I'll pause and I'll find that little crevice that I made, in front of the ureteral orifice and then go back because I want to reorient myself to the depth that I'm resecting to and also how far into the bladder I am. And that's really the most important part because it's very easy to get lost on these really big median lobes. With these really big prostates, I talked about sort of my process for breaking up the lateral lobe into two sections. But it's perfectly okay to only do one side. If you're doing a TURP with hypotonic solution and you're worried about the time of resection, it's already been an hour. You know that if you go beyond an hour to an hour and a half, you're putting the patient maybe at risk for harm. It's perfectly okay to finish one side and then see how they do. And a lot of men who have that big of a prostate, if you can resect one side, that actually is oftentimes enough to get them peeing and really happy with their voiding symptoms. And so it's perfectly okay to do sort of a hemi-TURP. And then, once you see how they do, you can see if you need to come back at a later date and do the other side. So getting into the venous sinuses, this is not something that I see a lot anymore because we do these so much with this bipolar device. We don't have the time crunch that forces us to fairly aggressively, in a fairly efficient manner, take swipes where sometimes we get down to a depth that's deeper than we want to be. So if you're into the venous sinuses, that means you probably perforated through the capsule a little bit and now it's bleeding pretty briskly. It is oftentimes hard to keep going in these circumstances just because oftentimes the bleeding precludes your ability to see very well. Sometimes it's also hard to effectively cauterize venous sinus bleeding. If you're at a stage of the case where you'd really like to keep going, sometimes what you can do is actually stop, put a catheter in at that moment, put them on traction, kind of flush them out a little bit and see if that is effective at tamponading the venous sinus bleeding. And then you can go back and finish your resection. That's been effective for me a couple times, is basically trying to stop, sort of tamponade with a catheter, flush, aggressively, and see if that's enough to allow you to continue with the TURP. Longer TURP times. So this again is not as much a problem with the bipolar TURP, but yeah, I used to, as a resident in the 90s and early 2000s, see TUR syndrome, in a handful of patients every year. And it always seems preventable, but it's always driven by our desire to finish because we just feel like, gosh, 10 more minutes, 10 more minutes. But that accrued time and accumulated absorption of hypotonic fluids really is impactful to the patients. Lasix can help. So if you're going beyond an hour, you can just prophylactically give some Lasix, and that can be very effective at preventing it. But I used to be pretty strict about time. So it was rare that I went beyond an hour and a half just because of the potential harms of it. Sometimes it doesn't work. It's a very effective treatment option, but sometimes it doesn't work. And, in my experience, the most common reason is because their bladder just doesn't work. The analogy I always make to patients is that, we are plumbers. I think we're pretty effective plumbers, but we're plumbers. And so in plumbing, right, it's either a pump failure or a pipe blockage. And it doesn't matter how open you snake that pipe. If the pump isn't working, there's still going to be no flow through the pipe. I have a tendency to sort of under-evaluate patients just because their subjective symptoms are typically so classic for BOO. And if they don't have any concomitant neurological disorders or diabetes, where I feel like they might have a hypotonic diabetic bladder, I have a low threshold to take them to a TURP. And sometimes it doesn't work. And, we get urodynamics after the fact, and lo and behold, they have a severely hypotonic bladder. It can be because you didn't take out enough, or you took out enough in one area, but you missed another area that, surprise, surprise, was impactful on their voiding. Commonly, this is apical tissue, so we tend to be shy around the apex because we're worried about incontinence. But sometimes that means we leave behind tissue that can still impact their voiding. And so it's not wrong to go back and take out more tissue. Sometimes they just need a little bit more time. Sometimes, their bladder, especially in people with chronic urinary retention, needs to cycle a little bit more. That's where clean intermittent catheterization is really helpful. If they're just wearing an indwelling Foley, their bladder doesn't get to cycle. But if they start doing CIC, their bladder gets to cycle, and they get to do that test of voiding where they're able to try to pee, catheterize, and see what their residual is. And so that's a much more effective way to manage these men who can't pee after a TURP. And then sometimes, you were just wrong. and their symptoms were not BPH related. And it was something else that was really driving whatever the most bothersome symptoms are. You know, I think it's just important to focus on these symptoms that are most specific to bladder outlet obstruction. You know, weak urinary stream, hesitancy, it takes them a long time to pee. Their pee is, you know, stop and start, and then they're not able to empty their bladder. I mean, these really are the bladder outlet obstruction defining urinary symptoms. So I hope that was helpful. I hope that was in line with the goals of the talk, and I'm happy to take any questions you guys have.
Thank you so much, Dr. Gore. For the questions, you can unmute yourselves or raise your hand to enter them into the chat box.
I worry that someone is talking and I can't hear them.
It looks like Dr. Adai, I think you might be trying to talk, but we're not able to hear your phone because of your internet connection. Maybe you can type.
Do you want to type it into the chat? I know that's a pain in the butt, but.
Yeah, do you want to type your question, Dr. Adai, just since your microphone isn't quite working?
Yeah, I see your hand raised, but I still can't hear you. I'm sorry.
Hello, Kati.
Ah, there we go.
Hi.
Hey. I went offline, sorry.
Okay.
Dr. Go, thank you for a very good lecture. I'm particular about continence post-TURP, and I'll be glad if you can throw a little more light on how to avoid. What do you see when you are at the sphincter area in order to avoid causing continence? Thank you.
Yeah. So, you know, I will say stress urinary incontinence after a TURP is mercifully uncommon. And a big reason why is because we have the VIRU, which serves as a very effective marker of the location of the external urethral sphincter. And so I definitely am shy at the apex. What I tend to do if they have a lot of apical tissue is I tend to use the scope as a retractor. And what I mean by that is if I feel like there's a significant burden of apical tissue that needs to be resected, if this is the apical tissue, what I'll do is I'll extend the loop and then I'll push the apical tissue forward as if I'm trying to push it into the bladder, and then I'll resect it. And then I kind of tend at the apex, kind of like I talked about with the median lobe and the bladder neck, where I take shorter swipes. I tend to do more shorter swipes rather than trying to do longer swipes. We have this thing, you probably have it too, the button. It's essentially like a new age vapor trode. And if it's a button TURP rather than a loop TURP, the button also is really effective at essentially spot treating the apex. And I find that to be really nice anatomically because you have just a lot of precision around the VIRU. I do see a lot of urge incontinence early after a TURP, and that can be really frustrating for patients. I find that urgency and frequency are two hallmark symptoms where if that's a big part of their symptom complex before the TURP, I will talk to them about potentially exacerbating their urgency and frequency after. And we can try to control that with medications or whatever it may be. But I always counsel them that the most important treatment in that is time. once they have, a new urothelial lining that's healed over the TURP defect, oftentimes that exacerbated urgency and frequency improves quite a bit. Dr. Dai, did you have any other tips about treating the apex with respect to continence?
No, I defer to your higher expertise.
That's
in
not
this
true.
instance. Thank
That's not true. But I do like that push forward move to try to push. You're essentially trying to push the gland into the prostate fossa, so you feel safer about resecting it.
Okay, that's fine. Thank you very much.
Thank you.
Have you had any instance where you caused complete incontinence, sphincter damage, and you had to put in an artificial sphincter, or let's say a male sling?
Yeah, knock on wood, I have not. I have one patient who this makes me think of, who had such severe urge urinary incontinence after, so not stress. So I don't think it's structurally related to the anatomy of the prostate post TURP, but he had severe urge urinary incontinence that we really struggled to manage. And it took a lot of trial and error to get him to have a better quality of life. And that was really challenging. But I have not had someone who developed total urinary incontinence after. But I would anticipate that would be a really challenging problem to navigate. Have you seen that before?
Yeah, my first URP ended up in a total incontinence, so we had to put in a male sling.
Yeah.
Unfortunately, we got overly continent, and it's quite tough actually.
Yeah.
It's actually almost nearly put me off doing TRP, but I've since moved on and continue to do a few more. Yeah.
And as you think back to that case, do you think you were overly aggressive at the apex of the prostate?
Yeah. That was a problem.
Yeah.
That was a problem.
And that's where just really like mapping out the anatomy of the prostate fossa is really important. Just being aware of where you are. I find especially when our residents are first learning how to do this, it's very easy to get lost. And my main job in teaching them is saying, think about where you are. This is where you're at. Especially in a big prostate, right? You're just focused on aggressively resecting the adenoma, and you just don't even realize how distal you are. And so taking the time to reorient quite a bit is important. I see Dr. Kagongo has their hand raised. Do you have a question, sir?
Yes, Dr. John, thank you for the good presentation. I have 3 questions. The first one, most of my questions, by the way, you've been answering them along the way. I've been wondering, but you've answered the most of them. So a few remain. The age of a patient for TURP, do you have a lower limit where you feel like a 45 or 55, and you think maybe this age, I prefer a higher age?
So for that, I would say that's a great question. Sometimes that interacts with family planning a little bit, so one of the first questions I'll ask a younger man is about family planning, because one of the jokes I always make to patients is, if you are still ejaculating after my TURP, maybe I haven't done a good job. And so, my expectation is that that patient is going to have retrograde ejaculation. And so if they are still, in terms of family planning, if they are still hoping to have kids, then even if it's a bigger prostate, I will sometimes attempt an incision just to see if we can maintain ejaculation, but still do something to help them have, improvement in their urinary symptoms. I find those cases to be, so usually an incision of the prostate is so satisfying, right? You cut the bladder neck, it wings it open, it feels so great. But sometimes in those cases where you're doing it on a bigger prostate in a younger man, you just see that you're almost like creating this larger median lobe, but they do pee better. So that's one of the strategies I use for younger men.
Okay. The second one is about the post-voidal residual volume. Do you have an upper limit that you, when you see, you say this one, surgery up front?
Oh, I use that in a more age-related way. So it's so funny because when I was a resident, we used to have this number that we were all taught of 150, like over 150 is a bad post-void residual. I dispatched with that long ago. Once you enter into clinical practice and you realize that, the PVR can be a function of their total bladder capacity. It can be a function of so many different things. And there are a lot of men who are running around with what we would consider to be an impressive post-void residual who aren't at all bothered by it. So I try to correlate it with the symptom burden, and I definitely use age as a cofactor. So if I see an 82-year-old man with a PVR of 220, I'm not usually that pressed about it. But if I see a 49-year-old or a 56-year-old man with a PVR of 220, then I say, no matter what, we might want to talk about surgery sooner rather than later. So it's sort of integrating all of that information into the decision that I think is really important.
Okay, and the PVR between 50 and 100 doesn't worry you much, does it?
Not really. Not really.
Okay, my last.
I do think I'm a little different than a lot of urologists where I do sometimes tolerate higher PVRs. I mean, I have some men in my practice with PVRs in the 300 to 400s that we're just watching, and I'm okay with it.
Okay. My last question is about the patient with the lower urinary tract symptoms who are maybe they are moderate lads and chronic kidney disease and hypertension. You're not sure whether hypertension is damaging the kidney or it's the prostate. Those who do not, for example, their renals don't improve on catheterization. Do you sometimes try medical therapy or still you say, let's get rid of the prostate?
Yeah, I feel like anatomically, if they don't have associated hydronephrosis, with their CKD, it's hard to make an argument that the BPH is a huge contributing factor. And, if they have other legitimate reasons for their CKD and their urinary symptoms are at most moderate, I'm not pressed about aggressively treating their BPH symptoms. If their symptoms are worse, what I often will say, because, you put a catheter in, their creatinine didn't improve. What I often will say is, these are the things that I think are going to get better. I'm not going to make any promises about your creatinine because we just don't know. It's not like that obvious situation of a patient that presents in urinary retention with a creatinine of 4.5. That's a much more obvious situation. Your patient is a little bit trickier, but I would gamble that it's mostly medical renal disease rather than anything obstructive.
Good. Thank you. Those are my questions.
Thank you for the great questions. I see it's 1 o'clock. I'm happy if anyone else has any more questions, but I'm also happy to give you guys the rest of your evening free. It's late there, right?
I'm in East Africa where now it's 10 p.m. East African, actually 11 p.m.
It's 8 p.m. in Ghana.
Oh,
It's 8 p.m. in Ghana, right?
Yeah.
Thank you for making time so late.
Dr.
Thank you
Gore,
very much.
Yes.
I have a question. I'm Roland. Thank you so much for this excellent lecture. I wanted to know whether you have any experience with channel TURP for a TAP patient, a patient with advanced prostate CA that you need to do channel TURP to improve the flow.
I do, unfortunately. Yeah. It's a tough situation. And what I struggle with, which maybe what you struggle with as well, is the endpoints are harder anatomically. It's harder to say, hey, I'm done. And that's why we call it a channel, right? Because what I find always happens in those cases, and I would love to hear your experiences. I find that I reach a point where I say, well, we're just going to have to be done now, and hope that the patient pees well. But I don't have the same anatomic delimiters that tell me, here I'm resecting the capsule, here I'm resecting the circular fibers. And I find those cases to be a lot more unsatisfying. The one good thing about those cases is I find they bleed a lot less because they tend to have a lot less sort of stromal blood vessels that bleed post-TURP. What has that been your
Thank
experience
you.
as well?
Yeah, thank you so much. The second, it has to do with poor visibility during TURP. Any tricks to improve visibility?
Yeah. So that can be really hard, right? Sometimes the visibility is bleeding related, and sometimes the visibility is just prostate anatomy related. When it's bleeding related, and your process is typically to resect to capsule before you get hemostasis, sometimes you just have to stop and get hemostasis. Sometimes you just really can't see until you get hemostasis. The other thing that I have encountered, this happened a couple months ago, is I didn't watch the resident put together the scope, and they actually put the inflow to the outflow and the outflow to the inflow, and I could not figure out why the visibility was so terrible. And I finally scrubbed in and I looked at the scope and they had it backwards. So definitely checking your instrumentation. But I think oftentimes if it's bleeding related visibility, stopping, even if it's not your usual process to stop at that point and get hemostasis, even knowing it might be preliminary hemostasis because you're going to subsequently resect over that blood vessel again, I think makes a big difference. That process of chasing a blood vessel down to its base is something that I think we all get a good feel for, but it takes a little bit of experience because it's sometimes hard to know where that stream is coming from. So I always back up to the viru, and then I try to follow the stream into the base, I guess with variable success. If it's anatomic visibility, where it's just a big bulky prostate and it's hard to make room, you just have to figure out where you're going to create room for yourself. In general, working posteriorly helps, but those are a little tricky. And then once you create a little bit of room, then you can start kind of figuring out the rest.
Thank you so much.
Thank you very much. Well, thank you guys for all the great questions. I really appreciate your time, especially given that it's so late there. So thank you very much.
Thank you too.
Grateful, Dr. Gore. Thank you too. And Kati, thank you very much for putting this together.
Yes. And thanks for organizing, Dr. Adai.
Thank you, Kati. Thank you, Gore.
Thank you.
Thanks, everyone.
Thank you.
Thank you.
Thank you so
Bye.
much. Bye. Bye. Bye.